Welcome to AETCM, the Holistic Medicine channel. Today we're discussing about a young female who came to her with complaints of ecchymotic patches all over her body since past few days. So a 38-year-old female was brought to here with complaints of low-grade fever, and following that she developed ecchymotic patches all over the body since past 3 days. And since the symptoms were persisting, she was brought to ER for further management. A 38-year-old female, she doesn't have any other non-comorbs. So on arrival, she was conscious or in obeying to my commands. I went to the primary survey. Her airway was patent. There was no signs of any obstruction or anything. There was no secretions or anything. Her respiratory rate was 18 per minute, and saturation she was maintaining 98% in room air. Circulatory part, she had a heart rate of 80 per minute, and blood pressure she was maintaining 130/70. And disability, she had a full score of GCS, and she was febrile on arrival. And went to the then primary adjuncts as such, nothing was necessary because the primary survey was within normal limits only. So went to the secondary survey. So basically, she had developed acute onset of some like generalized body ache and fever 3 days back. And after that, she started developing small patches all over the body. It was like a light red in color, then it became darker in color, and it appeared all over the body since past 3 days. So since it was appeared to be worsening, she came to the hospital. And since she was not feeling well, she directly came to the ER for further management. She doesn't have any non-drug allergies or anything in the past, and also the only drug she is taking is Thyronol, 50 microgram. And yeah, and also there was no significant events contributing to the event. Like there is no any recent history of any injury or anything that contributed to the event. And also, she was not complaining of any other like symptoms. There was no history of any cough, breathing difficulty. There was no abdominal pain, vomiting, loose stools, or anything. And considering the ecchymotic part, she doesn't have any other complaints like any bleeding from gums while brushing teeth or anything. Also, there's no history of any nosebleed, no hematuria. Also, she didn't complain of any joint pain as such, which we could give a suspicion of any hemostasis or anything like that. So her only complaint was some mild fever and some rashes all over the body. Since actually she was complaining of some pain, we gave 1 gram paracetamol on arrival, but she was otherwise febrile. And considering her history and this thing, clinical presentation, we sent for a routine blood evaluation. And it came to be this thing, her hemoglobin was found to be 5.4, along with her coagulation factors, APTT came to be 53.7, but INR was normal within 1 point.
APTT is double,
53.7, and INR was 1.1. But all other parameters within normal limits. CRP and all were within normal limits was only 14.9, and other LFT, RFT, everything was within normal limits only. But considering her history, she was admitted for further evaluation. So basically, this is a young female. She came mainly with complaints of some fever and rashes all over the body. And on evaluation, she is found to have a low hemoglobin with some deranged APTT value. So with the probable diagnosis of like hemophilia-like symptoms, we sent for a study, like a total coagulation workup was done. And in that, again, we sent for a total factor assay. That the factor 8 came to be too low. The expected range is between 60 to 150, and she was having only 4%. And factor 9 was within normal limits, and also von Willebrand factor was also within normal limits. So basically, she is having a deficiency of factor 8 in the study. And considering her actually like a late onset of disease with no other previous history in the past, we were in some more suspicion of more like an acute hemophilia. So we also went with a mixing study. And
what are the causes for APTT elevation?
APTT
isolated APTT elevation.
Isolated. I think it's basically APTT is mainly showing a issue with the intrinsic
pathway of the coagulation
pathway. So suppose the patient is having isolated derangement of APTT, we have to think about hemophilia.
Okay.
Or snake bite.
Okay.
But in combination, even
any drugs? Which
like
drug?
Heparin can cause elevated APTT.
Okay. Warfarin increases PTNR.
Also, in some cases, low molecular weight heparins also can reduce derange APTT. Then acute liver failure.
Initial phase of liver failure, APTT can be elevated, but afterwards both will elevate.
Then vitamin K deficiency again can affect. Then
vitamin K deficiency normally produces PTNR elevation.
Then any autoimmune diseases contributing to that. And also any DIC or anything sometimes.
DIC also both will be elevated.
Both will be
PTNR and APT. Early DIC can produce elevation of APTT, but afterwards both
will be elevated.
PT and INR will PT and APTT will be elevated. Okay, here only APTT is elevated. So you have to ask for a mixing study. What is mixing study?
Basically, if a patient is coming with like elevated APT in suspicion of hemophilia, we have to do a mixing study in which actually the sample of the patient to the sample of patient we add each factor separately to see if the defect is getting corrected, like the APT is coming back to normal. Then actually we can rule out.
Actually, we are not adding factor alone. We are adding
the serum.
Serum, plasma. That contains all coagulation factors. So normally after adding that, it will be corrected. But if it is not getting corrected, then
we have to suspect the presence of any inhibitory factor.
Inhibitors or antibodies against coagulation factors, factor 7 or factor 8. Okay.
So basically, this patient actually it was not getting corrected. So we went ahead with the next test, that is inhibitor screening. In that actually we go for something called a classical Bethesda assay.
Okay.
And the normal value should be less than 1 BU. And this patient we got a value of 36.8 BU.
Okay.
Mainly for the factor 8 inhibitor level.
Okay.
So this patient is having an
So this patient has got an elevated APTT. In mixing study, it is not getting corrected. So it is a inhibitor or antibody against the factor. Okay, that is a problem here.
And also the Bethesda assay has come to a very high value of 36.8. So that is actually what the patient is having. So basically the patient is having an acute hemophilia with an inhibitor assay of very high value.
Okay. What is age of the patient is very important here. What is the age of the patient?
38.
38. So you have to suspect a acquired hemophilia, not a congenital problem. Okay.
So basically hemophilia we usually seen in a congenital issue and also more in males than in females.
Okay.
Because it's an X-linked this genetic pattern. So usually the females will be carriers and the males will be usually affected.
Okay.
So suppose that we are getting a patient with an acute hemophilia, we have to think about other causes which may have contributed to this acute onset. Like maybe any malignancy we had to rule out, also any autoimmune disease like any Sjogren's syndrome or SLE or something which can flare.
Most common thing is SLE and systemic sclerosis. And Sjogren's syndrome also can be there.
So these things we have to rule out.
Other malignancies, lot of hematological malignancies can produce like leukemia, lymphoma, so many multiple myeloma, so many hematological malignancies can produce this problem. So we have to rule out all these things.
So this patient actually, from our initial evaluation, we couldn't find an actual cause for this issue. But
50% of the acquired hemophilia we will not be able to comment on any cause. 50% only. In that 50%, commonest is rheumatological disorders.
Issues. But considering her clinical status, she was hemodynamically stable, so we had some time to address the issue. So the main issue in this patient is having ecchymotic patches, and secondary is actually she is having low hemoglobin. So we give correction for that, but
why low hemoglobin in acquired hemophilia? Hemophilia is a condition where there is bleeding occurs. Why this patient has developed anemia?
That's what the source of bleeding could not be identified. Actually, we went with the chest X-ray. We go for a USG abdomen. There was no free fluid in the abdomen. There was no signs of any hematrosis, any localized collection in her body. There was no history of any headache or any signs of any isolated bleed or anything. But it's more like an occult bleeding, something somewhere happening in the body, which is contributing to the low hemoglobin.
What else? It could be occult or it could be just auto-destruction of the RBCs.
What is that?
Itself.
Hemolysis.
Hemolysis could also
Immune-mediated hemolysis. So we have to suspect that also. Somebody is having a immune-mediated destruction of the coagulation factors, which can be secondary to an immune-mediated disease like SLE or antiphospholipid syndrome, whatever it is, or malignancy. If the patient is having anemia like this, we have to rule out hemolytic anemia. Okay, how do you rule out hemolytic anemia? Tell me one test which will rule out hemolytic. LDH is hemolytic. All these things will rule out hemolytic anemia. I am asking about autoimmune hemolytic anemia. One test. Coombs test. So ideally we have to do Coombs test in this patient, but we have to, first of all, we have to find whether it is a blood loss anemia or hemolytic anemia. If it is hemolytic anemia, you should never forget to do a Coombs test.
We also did a peripheral smear for this patient. It was showing normocytes, normochromic, normocytic this RBCs.
Okay.
And platelet count was 1,75,000.
Okay.
And also, so the initial final impression was leukoerythroblastic blood picture. That's
What is leukoerythroblastic blood picture?
basically
More amount of
more and more of
leukocytes.
blast. I mean, early forming.
Early forming. That means
RBCs
peripheral mostly there is a peripheral destruction and bone marrow is hyperstimulated. Either a peripheral destruction or an increased loss, acute loss, that produces leukoerythroblastic blood picture.
So basically, young RBCs are in the circulation, more in the circulation.
Leukoerythroblastic, both are young.
Yes.
Both leukocytes and erythrocytes are young.
So this patient actually post admission, our priority was to one is to diagnose what is going on. So initially we in the initial blood test we look for any drop in platelets which may have got the secondary patches was normal. Secondary went with the coagulation assay in which we found to have low factor 8. Then the third was mixing study to find if there is any presence of any autoantibodies to the factor. So again, since we're not getting corrected, we are suspecting in more like a inhibitor factor present. So we went with the Bethesda assay, which came to be positive. So this patient is basically having an acute hemophilia type A, affecting the factor 8. So basically the treatment part actually, even if we supplement with factor 8, the patient's condition may not get reverted. So the treatment plan will be like on a different basis. So in this patient, the approach was first to support the
So
patient.
if you give factor 8, what will happen to the patient?
It will again get distracted. So
It will be destroyed. So you cannot give a human factor 8. That's all. You can still give artificial, recombinant. Okay.
Recombinant varieties actually may not have that kind of an effect from the destruction part.
Okay.
And also other things we can try is actually we can supplement factor 7 like in high doses which can actually accentuate the extrinsic pathway.
Okay.
So basically once the intrinsic pathway is actually lacking due to any lack of factor 8, one option we have is actually to add more factor of the other pathway.
Okay. Factor 7 can be added so that factor 8 will be produced.
So also that line of coagulation cascade will be more active. So and the second option
there is one option. You add previous factor so that current factor will be overproduced. Okay.
Second is actually to suppress this autoimmune or antibody effect in the body. So one drug we have choices is emicizumab.
Okay.
It is actually used as a routine prophylaxis in patients of hemophilia A with mild symptoms, but also can be tried in this kind of patients.
Okay.
And the second option will be rituximab.
Okay.
So both these drugs the main action will be to suppress any auto antibody action in the body. So basically the even less than 5 nanogram of hemophilia factor 8 is enough to it's adequately required for a normal person with for adequate coagulation. So suppose the patient is having suppose a borderline of less than 1 or something, even the supplement of this drug can actually raise this value to adequate amount for that a normal living.
Okay.
So one is supplementation of factor 7, then drugs like rituximab or emicizumab we can give, and third, in an emergency condition like in an ER or something, the patient is having acute bleeding due to some trauma or something, we can go for cryoprecipitate.
Okay. So but will cryoprecipitate will be effective in this patient?
This patient actually again the issue will be it will also be destroyed. The
cryoprecipitate is advised in a hemophilia of congenital origin, not in acquired form. It can be given, but it will be destroyed.
So a patient coming with hemophilia, our primary management will be initial resuscitation and any hemorrhagic control, whichever is way is possible.
Most common hemorrhages are to which space? Common.
Mainly joint spaces.
Joints and muscles. They are the two important areas where patient can have bleed. Large bleeds into joints and muscles.
So it can even be retropharyngeal or retroperitoneal spaces can also be.
So the hematomas and infections can occur.
Then also if the patient is complaining of any headache or anything, we suspect any IC bleed, which can also be common in this kind of patients. So coming to the basic pathology, so if a patient is having any injury in any vessel, the first this response of the body will be to go for some vasoconstriction, local constriction. Then the platelet in the circulation will go and clump in that area. So it is called primary hemostasis.
Okay.
So it will actually temporarily stop the bleeding. And from the injured area, some tissue factors will be released. And
from that platelet itself, tissue factors will be like aggregation factors will be released.
So aggregation factors will be released by the platelets, and the tissue will release tissue factors or tissue collagens. So tissue factor will go and activate the extrinsic pathway. So it mainly acts on factor 7. the factor 7 gets activated to factor 7A, and this in turn activates factor 10. So from factor 10, there is actually called the common pathway. So factor 10 actually again combines with factor 5 along with 2 and all. The final end result is actually prothrombin gets converted to thrombin, and this in turn converts fibrinogen to fibrin.
So we can do fibrin levels in our lab. What is the advantage of fibrinogen levels in lab? What it can pick up?
Basically,
Both intrinsic and extrinsic pathways are damaged. Then you can see fibrinogen levels are low. Okay. So severely low fibrinogen indicates disseminated intravascular coagulation. So both pathways are destroyed. So fibrinogen levels will be very, very low. Okay. Then only you can give cryoprecipitate. But here we know that there is a problem. Cryoprecipitate can be given first itself. But it will not work in this condition. What case we are discussing.
So extrinsic pathway, basically the main role is for factor 7, which comes to the common pathway, and the final end result is actually fibrinogen getting converted to fibrin. This fibrin will actually form a mesh work over the platelet clump, and it forms into a final clot.
Okay.
That is secondary hemostasis.
So platelet produces platelet disorder produces minimal bleeding, but whereas coagulation defects produces larger bleeding.
So even if a patient is coming with clinical history of like minimal early bruise and all, it's more in favor of a platelet disorder. But a patient is coming with a large hematorosis or large collection of blood, is more in favor of a coagulation disorder.
Okay.
So this is the extrinsic pathway starting from factor 7, and also intrinsic pathway starts from factor 12. And also the main role is for factor 8 and factor 9. And so basically the cascade will go from like 12 to 12A, 11 to 11A, 9 to 9A, like that. So the end point is actually again joining to the classical pathway starting from 10. So but the absence of factor 8, we call it hemophilia A, and factor 9, we call it hemophilia B. So these are mainly seen in acute conditions in young people, mainly in males, because it is an X-linked genetic disorder. So suppose the patient is getting this in a later stage, like in this patient, we have to think about other causes. The treatment plan for a patient with acute and this thing is different. So initially, if it's a non-case of hemophilia patient, there is no point in like again going for further testing or APTT or anything. Our primary aim will be to supplement whichever is factor deficient as early as possible.
Okay.
So a non-case is coming to our hospital with the complaints of like any bleeding disorder. Our aim will be to like get his previous medical records and then contact our hematology department to arrange for the factor as early as possible. So like depending on the injury, the dosages will also change. In hemophilia A, the dosage will be like from 10 to 20 micro international unit per kg will be like the initial dose, which we repeat every 12 to 24 hours. And as the injuries increases, the dose also increases. So in severe bleeding, we have to go up to 50 international units per kg dosage have to be given, especially in case of IC bleed and also intra-abdominal bleeds. So basically, supplementation of actual factor is the primary treatment for congenital hemophilia. And in our case, the main state of treatment will be like hemodynamically, we have to support the patient and go for second line of management.
Okay.
So this patient actually, she didn't have actually any initial issues of like huge like bleeding or anything. So we had some time to manage the patient. So her hemoglobin got corrected by transfusions, and there was no any further drop in hemoglobin. And she's currently undergoing like further treatment for her acute hemophilia.
Okay.
And suppose the patient is having a congenital hemophilia, in an emergency situation, we can also give cryoprecipitate.
Okay.
So cryoprecipitate basically, for a normal patient, we can give 1 unit per every 10 kg. So it raises the level of, like mainly in case of DIC and all, it raises 1 gram per deciliter of fibrinogen for every unit. And usually a normal adult will require about 4 to 6 or even up to 10 packets of cryoprecipitate will be required in acute emergency. So that's mainly for hemophilia.
And blood transfusion was tried in this patient?
Yeah.
Okay.
After blood transfusion, actually she was maintaining her
Okay. Past history of blood transfusion was there?
No.
Because blood transfusion itself can produce sometimes acquired hemophilia. That is a problem.
Okay. Suppose so a hemophilia patient, our ER management basically we have.
So basically, when you get a patient who is having elevated APTT without elevation of PT, hemophilia is the first differential diagnosis. Then heparin, whether the patient has taken heparin unknowingly or somebody has treated with heparin. Third one is other causes for secondary or acquired hemophilia. If it is not a hemophiliac patient, you have to rule out causes for acquired hemophilia.
So basically, any patient coming with complaints of bleeding, we have to first initially resuscitate and stabilize the patient, then go for basic investigation. First will be to look for any like HP levels and all that, and platelet, and also the coagulation INR and APTT values. Depending on that, if the APTT is high, the first differential will be this hemophilia if not diagnosed earlier. And otherwise, if the patient is on multiple other drugs or other issues, we have to sort that out. And the second will be like, if it's a non-case, we have to arrange for factors as early as possible. Not a non-case, we go for further evaluation on one side, and the other side we have to rule out any acute emergency in this condition. This patient, from head to toe, we have to rule out any causes of intracranial hemorrhage, any retroorbital hemorrhage, any oral bleed or any nasal bleed. Any difficult in swallowing anything, we have to rule out any retropharyngeal bleed or anything. Then the patient is complaining of any breathing difficulty or something, we have to rule out any pleural effusion, which we can take by X-ray and rule out. And pleural effusion, bleeding into the lungs, which is all very common in this kind of patients. And if the patient is complaining of abdominal pain, we have to rule out any intra-abdominal bleed also, which we can initially go for a basic USG abdomen or something, and maybe even CT as required. And also, these patients very commonly we have to rule out any bleeding into the joints, which will require emergency orthopedic intervention to let out the bleed. And also, suppose we are getting an occult like drop in hemoglobin, we are suspect any like retroperitoneal bleeds also, like into the psoas major muscles and all that. Also, possible compartment syndrome in the later stages. So these are the things actually as an emergency physician we have to like consider when a patient is coming with a non-case of hemophilia in our condition. And also, early factor replacement is our primary mode of treatment. So this patient with an acute hemophilia, we went for the second line of treatment, and she is now stabilized. But the exact treatment of this thing is mainstay of treatment is still under evaluation, like we have to begin. But so
since it is acquired, rituximab may be very helpful.
So it's the second day of admission, and she is so far hemodynamically stable. Her HP has came up. Otherwise, she is maintaining. Okay.
The APTT still
APTT actually
last APTT
is 24.
That has come to normal. So she is responding to the treatment. Okay. Anything else you want to tell? Thank you.
Thank you.